Hello, my name is Dyann Daley. I'm a pediatric anesthesiologist at Cook Children's Healthcare System in Fort Worth, Texas, and I'm here today to present on the prevention of child maltreatment. Every year in the United States, between 1,500 and 3,000 children die from child abuse and neglect, and 75% of the victims are babies and toddlers. According to a report from the Commission to Eliminate Child Abuse and Neglect Fatalities, which was completed earlier this year, more than half of these children are not known to child welfare when they die. Now, some of the solutions that people have been looking toward to figure out how to find them when they're still in a vulnerable state before they're injured are based on looking at personal characteristics that are contributory to abuse and neglect. And these are the things that we all know about, like being a very young age, the age 0 to 1 being at the highest risk, children that have disabilities, developmental delay, prematurity or chronic illness, young single parents with low education, poverty or multiple children, unhealthy parenting norms and physical punishment of children, parents were experienced maltreatment as children themselves, parents lacking parenting knowledge, parental substance abuse, mental illness, having a transient caregiver, and social isolation. Unfortunately, looking at these factors alone on a person basis has not been particularly successful in predicting which child is going to be maltreated or which family is likely to abuse or neglect their child. And we know this, again, from the Commission to Eliminate Child Abuse and Neglect Fatalities, that the best predictor that a child is going to die of an injury before age 5 is a call to Child Protective Services. And what that really means is that these risk assessments and strengths assessments and safety plans that are done don't add significant information beyond just that call when it comes to predicting the death of a child. Other people have looked toward person-based predictive analytics, similar to what a lot of police stations are doing across the country right now, and which failed in Chicago. Looking at person-based characteristics to try to determine which people are going to commit crimes has failed multiple times in multiple cities, and it has also failed in child maltreatment prevention. So if we can't look to individual factors to identify children at a greater risk for child maltreatment, what can we look at? Well, we know that the people that are most likely to notice children that have been abused or neglected are healthcare professionals, which we know do not recognize or report findings that are suspicious for child maltreatment the majority of the time. The next option is teachers, but the children at greatest risk, age 0 to 3, aren't in school to be noticed by teachers. And the third category are police. So once the police are involved, there's already something seriously wrong in the environment. And so all of the typical reporters that are useful in finding children when they're a little bit older are not as helpful in the 0 to 3. So how do we find them? Well, looking at the context changes the entire idea around how to prevent child maltreatment. So we know that early childhood adversity, as described originally by the Adverse Childhood Experiences Study, describes what the types of health and social and mental health outcomes that children will experience in the future. We also know that social determinants of health, which describe the environment of a child, can also be predictive of all sorts of health, social, and educational outcomes. So instead of looking at individuals, what if instead we looked at the spatial dynamics of all of these factors together to see if it could predict where child maltreatment might occur in the future? So that's what we did. We borrowed a tool called risk terrain modeling from Rutgers University. And what risk terrain modeling does is it looks at the context in which crimes occur. Now, this was originally developed, obviously, in the criminology field, but what it does is it can predict rare crime events based on just the context without looking at any sort of person-based predictive analytics. So, for example, this is just an example of one of the studies. You take a shapefile of the city that you're looking at or the geography you're looking at and make individual layers of the different types of of activities or crimes or infrastructure or other variables that are known to be contributory to that outcome. And then you compare all of that against what you're looking for. In this case, they were looking for shootings. So they compared all of the different factors that could contribute to shootings against actual shootings, and then they could take that information to predict where shootings would occur in the future. Now, this is the work of Joel Kaplan, and if you want to hear a really great talk on how you can apply this type of predictive analytics to prevention, he has one from TEDx. And what he showed in his presentation, with his permission I'm sharing this with you, is a little bit about the risk terrain modeling process. So essentially what you do is you find factors that are known risk factors from the literature that predict or contribute to the outcome that you're looking for. And then you try to find the combination of those factors which then predict where that outcome will occur in the future. And then what you can do with that is look at the different factors that actually contributed to your outcome, and you can start to change those factors individually. And I'll get into more detail on that when we start to talk about child maltreatment. With risk terrain modeling applied to crime events, people across the nation have used this technique and have seen a significant reduction in the crime that they were trying to prevent, which is something that is very hard to demonstrate with any prevention program that exists currently in child welfare. So what we did at Cook Children's Center for Prevention of Child Maltreatment was take risk terrain modeling and see if it would work with child maltreatment. So from the state of Texas, we took a couple of years to gain access to address level child maltreatment data, which was our dependent variable. And then what we did is we searched the literature to find what types of risk factors for child maltreatment are known and well established in the literature that we can actually look at an address level. So a lot of this information is going to come from crime type situations. So for example, if you're looking for drugs, drug arrests is a proxy for that. Or if you're looking for domestic violence arrests are a good proxy for that. And then what you do the same thing as I described before. You look at your geography, you apply a grid over whatever geography you're studying. In our case, we were looking at Fort Worth. The grid size is based on the population density of that area. And then we compared known address level child maltreatment cases against all of these different address level risk factors to generate a model, a predictive model for child maltreatment. And what we found was that using the optimized model, this is where the forecast predicted child maltreatment would occur in the following year. So just like a weather forecast, these are where the factors align to be conducive to child maltreatment. And in the following year, we were able to capture more than 98% of all child maltreatment cases that occurred in our city in the risk cluster areas identified by risk terrain modeling. Now, since then, we have adapted the model even further and improved the prediction accuracy so that now we can still predict 98% of child maltreatment in 40% of the city's area, more than 80% in 20% of the city's area, and almost 60% in just 3.7% of the city's area, which is a huge advantage when you start talking about allocation of resources and alignment of strategy in these small geographic places. And these are the model specifications from our updated model. Our original model was published in Child Abuse and Neglect in December, and I'll make sure there's a link to that article here. Our second model showed that if you have in a football field sized area, domestic violence, the presence of a runaway where a child runs away and then is returned back to home by a police officer, that's where you get the address, aggravated assault and sexual assault. The density of those crimes occurring in a football field sized area is predictive of whether or not child maltreatment will occur in that area, and all forms, age 0 to 17, all types. So we were really excited about that because not only do the variables that go into this predictive model, they're objective. A domestic violence arrest or an aggravated assault arrest, that's not going to be something that can be perceived as a profiling type arrest or a loitering charge or standing somewhere suspiciously. I mean, we're talking about a violent act that left marks on a person and resulted in an arrest. So we know that this is a more objective way of looking at risk factors, and also with the model, each risk factor is ranked according to relative risk. So we know that if we really want to make an impact on prevention of child maltreatment in these risk cluster areas, we need to be focusing on domestic violence, which is a shift from the current focus, which is traditionally poverty. Then we wanted to see, well, is this where you actually find the little children that die from child maltreatment, especially the beatings and stabbings that sometimes, or shaking, or impact that often affects the youngest children, the age 0 to 3. And what we found was that if from our medical examiner data looking between 2010 and 2014 at all types of child fatalities, we found that 17 of 24 child homicides in the age 0 to 5 group occurred inside of risk cluster areas. We found that 10 of 11 firearm shootings or stabbings, mostly gang violence related, occurred inside of risk cluster areas. And then we thought, well, knowing that these risk cluster areas that we're predicting are particularly dangerous for in the context of child maltreatment, we know that these children are being chronically exposed to violence, to sexual violence, domestic violence, and other types of crimes which also co-occur in these areas, like drug abuse or drug crimes and others. So we wanted to test the idea of whether or not we need to screen these children to know whether or not they have accumulated 4 or more adverse childhood experiences. Just logically, it would make sense that they should all have at least 4, just based on the environment where they live. And so to test that, we again went to the death data and started looking at toxic stress health outcomes that are primarily based on the pathophysiology of toxic stress. So asthma is one of the childhood diseases that can be related to early childhood adversity. And we found that 7 of 7 child asthma related fatalities occurred inside of risk cluster areas. We know that there are a wide variety of psychiatric and behavioral problems associated with adverse childhood experiences, including suicide. And we found that 13 of 19 child suicides occurred inside of risk cluster areas. Now, of course, this is also going to be the place where the kernel density of drug offenses overlap or also occur because of the types of neurodevelopmental changes that we see in children that grow up in these environments, where their frontal lobe becomes a little bit less connected and their threat center becomes more connected. As these children grow older and are more hyper-responsive to threat, they're going to want to kind of take that down a little bit to modify the way that they're feeling. And of course, drugs, alcohol, cigarettes, eating, and other types of risk-taking behaviors can become a crutch. So of course you're going to see these types of behaviors in these areas. But then we wanted to look at child injury. We know that the causes of unintentional injury death in children are the same in accidents as they are in maltreatment. So drowning is a category that crosses all age groups for children, and is also an important cause of maltreatment related to fatality. So we looked to see where the drowning deaths occurred, and we found that 14 of 14 accidental drowning deaths occurred inside of risk cluster areas. We found something similar with suffocation, which is the leading injury-related cause in children less than 1 year old, and also an important cause of acute neglect-related fatality in infants, because if a caregiver is drunk or high and inappropriately caring for a baby, such as bed sharing, then suffocation is, of course, much more likely. And what we found was that inside risk cluster areas for child maltreatment, 57 of 77 sudden unexpected infant deaths, which include SIDS and suffocation, occurred inside of risk cluster areas. Now, not surprisingly, considering the neurodevelopmental aspects of early childhood adversity, we wanted to see if early childhood learning was affected in these areas in any particular way. So we know that children that come from places like this, where they have issues with social determinants of health and with adversity, are going to have alterations in their neurodevelopment when it comes to their ability to learn. I mean, they're focused more on survival than they are on learning new things. And so it makes sense that the children coming from these places would have they wouldn't be as ready for school. They're going to have decreased readiness, and they're not going to do as well in their early years. And so we compared where our risk clusters were located against school districts or elementary school catchment areas where we know the third grade reading level is way below what we want it to be. And what we found is that while these elementary school catchment areas, the ones that are in particular trouble are here in red, they don't line up exactly with poverty, but they do line up with violence. So now we have defined where and what we need to be focused on. So how do we help these kids? Well, back to the Commission to Eliminate Child Abuse and Neglect Fatalities. Their recommendations, after going all around the country and doing lots of interviews with people in town halls and this sort of thing, they came up with these recommendations: that we need to have an increased emphasis on child death reviews, that we need cross-sector training and collaboration, that prevention programs need to have more accountability, and that we need to avoid high-cost interventions that don't show effectiveness, that have low effectiveness. And they specifically mentioned long-term group care and generic parenting programs as high-cost interventions that have low effectiveness. So if you think about what this map adds to this equation, so this is the 20% of the city's area. So if we know where children are in trouble in 20% of the city's area, we can start to align resources. And we can even get more specific by taking it down to the 3.7% of the city's area where almost 60% of child maltreatment occurs. So the first thing that we did in looking at this is identify inside of these risk cluster areas, where are the schools? What are the healthcare clinics, dental clinics, community centers, fire stations, police stations, faith communities, anything that we could think of that would be a place where some sort of prevention activity, whether it's community-based or programmatic, could be delivered. And then we started looking at what sorts of interventions could we make in these places in collaboration with all of these organizations and people that would make the most difference. So in two areas of the city, it's true for the entire city, but there are two areas in particular that have a lot more problems than the rest. We look to see what type of substantiated child maltreatment is occurring in these places, and what we found is that physical abuse makes up about 30% of substantiated child abuse in these places. And as you know, that's almost double what it should be based on a state and national average. And we also know that 60% of child physical abuse begins with physical punishment of children. So what's our best asset to try to fight against this? Well, if you look at the risk cluster areas where we know child maltreatment is likely to occur, you can see that there are a multitude of faith communities. So in this example, I think that there are 71 faith communities inside just the 4% of the city's area that is at highest risk. And you can also look in these same places to help encourage people to understand the severity of the problem, where the beating deaths occurred in little children. And you can see that it all lines up nicely. So by using this type of visual information, we can then begin the discussion about introducing programs such as the No-Hit Zone, which came out of Rainbow Babies and Children and has been implemented in more than 30 pediatric hospitals in the United States, and essentially promotes an environment of nonviolence. We have also looked into adapting Cure Violence, which is a gang and gun violence intervention program where they essentially hire people from the highest risk communities, train them, and then continue to pay them full time to go back into their communities and start changing social norms around violence. They are people that the other people in that community are comfortable calling if there's some sort of event that is happening, so that they can go there and try to de-escalate the problem before it turns into a killing. Or if someone is killed, they can then go in and try to prevent retaliation. And with this method, this program has been incredibly successful in multiple sites worldwide in decreasing the number of shooting deaths as long as the program is ongoing. In fact, if you even look at Chicago right now, which has an incredible problem with murder, there's one neighborhood that still hasn't had an increase in murder, and it's the only one that still has an active Cure Violence program located in that city. So what we're working on is adapting the same sort of concept to domestic violence and child maltreatment, which also centers around cultural and behavioral norms. By introducing a program like Cure Violence, not only are we bringing more economic opportunities to that community, but we're working to change social norms from the inside, which of course is going to be more effective than any outside person going in and trying to make a difference. Another project that we've been working on here at the Center for Prevention of Child Maltreatment is a project called Survivors Like Me. It hasn't launched yet, but it will very soon. We have a Facebook page, and what we did here is we went and interviewed survivors of terrible traumatic events or childhood trauma. And what we talked with them about was not the terrible thing that happened to them, or how wonderfully they're doing now, but about the middle phase, from the day you got home until you started having a balanced and healthy life again. What did you go through? How did you do it? What were the steps that you took? What was the healthy thing that you did? What was the unhealthy thing that you did? And the purpose of this is to give people that are in kind of the throes of trying to recover from something terrible ideas that they can improve, and also inspiration that there is light at the end of the tunnel, that they can get better, that they can improve and have a beautiful life. Another project we've been working on involves sudden unexpected infant death, specifically focused on suffocation. So we noticed by mapping the deaths that infant suffocation and SIDS are often co-located with child maltreatment. And we started to look around at all the programs that are being offered in the city, and we wondered, are the programs that are going into these areas all saying the same thing? Are they giving people the same sorts of instructions about how to keep their infants safe and how to prevent suffocation? And of course, what we found was that they weren't. And so we embarked upon a collaboration campaign that was citywide with all of the birthing hospitals in town, with the goal of having a unified, singular platform where all of us were sharing the same information, the same teaching points. We would have the same policies, the same sort of modeling of safe infant sleep behaviors in the hospitals, and uniform training of all of the different health and social care providers in the facilities, so that we would know for sure that no matter where someone came from in the city, that they would be receiving the same information about the importance of breastfeeding and the importance of a safe infant sleep environment. And since we initially began, 2 additional hospitals and a lot of nonprofit organizations have also joined. We're also emphasizing the importance of collecting and reporting the most accurate and the most helpful data for prevention. Now, I've learned that it's not necessarily true in all places or in all states or all cities that people are using the recommended form from our Center for Disease Control on reporting sudden unexplained infant deaths, which provide the context which allows for an appropriate discussion of that death so that prevention opportunities can be recognized. So that's something that anyone can do right now, is by writing to their officials to promote the use of this type of form. Now, all of this information, if you're interested in more about the Safe Infant Sleep Initiative, which is kind of a subject of its own, is available on our website. All of the materials are free here. So go to preventchildmaltreatment.org if you want to see more about that. Now, other things that you can do with location-based information is look at infrastructure. So this here shows you a small area and the public transportation system. So these are the bus routes. Now, if you look at the same area with an overlay from some areas where risk is much higher for child maltreatment, which you see here, you can see that there's a deficiency of a critical service. So the blue dots here represent licensed child care facilities. So you can see that in the red areas, you don't really have any licensed child care facilities that are either inside the area, so maybe walking distance, or that are easily accessible by the bus routes. So if you have a young mother in this area that is in trouble, let's say she's not even in trouble. Let's say she's 2 weeks postpartum, she has to go back to work and she needs somewhere for that baby to stay. It's going to be a lot easier for her to leave the baby at home with the boyfriend than it is to take them to a child care facility based on transportation constraints and other. So if we want to prevent abusive head trauma in infants, we can try to get through to men and women, mostly men, that might shake or hit or submerge or beat an infant, or we can provide the mother with a better child care solution. I think that the child care solution is probably more practical and then would also provide the child with an early learning opportunity, which is, of course, one of the most important things that we can do to prevent poverty. We can also align services like legal aid around locations where we know women are experiencing things like domestic violence to make their exit from that situation a little bit easier. Other approaches that we're introducing include crime prevention through environmental design. By recognizing areas where there is significant risk, you can also find specific locations inside those areas where violent crimes are much more prevalent. And to prevent those, you can look to crime prevention through environmental design, which essentially looks at improving the line of sight, improving visibility with lighting, perhaps changing the way that the police are patrolling that particular area. There are lots of things that can be done to improve safety in very dangerous environments. Well, sometimes people will say, well, that's all great, but the people that are in trouble, the children that are in trouble, how are you going to change the behaviors that surround those children? Well, we've already talked about one potential approach, which is taking a social norming type of approach, as they do with Cure Violence, to kind of work on changing the culture through education of certain influential people who then can go back into the community and spread the word. But there are other things that we can do as well. Taking a page from business, we started to look at psychographic analysis and market segmentation to see if that could be used as a resource for prevention. So looking at a generic block group, often when we work on prevention programs or even something like foster or adoptive recruitment, we'll look at an area like a generic block group, which is about 250 households, and we'll put up a billboard because we think that because the people that are there are demographically similar, that they're likely to be influenced by the same ad. But we know from psychographic analysis that that isn't the case. So for example, courtesy of the Buxton Company, we know that people that live in certain locations have very specific preferences. So for example, we know from Buxton that if you live in this black dot house, for example, that you're likely to be 45 to 54 years old, you're college graduates, you have teenage children, you like to wash, law, and order, you dine out 3 times a month, you lease your vehicles, and you shop at Sam's Club. Now, this type of information comes from all of the things that we do online and through the mail, essentially anything that can be related back to your address. So shopping, anything with a credit card. So what psychographic analysis does is it looks at our preferences for news and magazines, interests and hobbies, our wearables, what we shop for, even property and utility bills. For example, if you live in an area where you're drought restricted and you're still using more water and being charged for more water, you could make the assumption that that person may not be particularly environmentally conscious. So that's an example of what I mean. Finances and insurance, how we use our mobile and email, travel, charity contributions, the kind of cars we buy, demographic information, which is what people usually look at in the social setting, television, either on actual television or online, social media, and also our location. So all of these things relate back to our address. And what psychographic profiling and market segmentation does is it looks at the patterns that exist across populations in what they purchase. And we're all kind of familiar with this just based on Netflix, for example. I mean, Netflix knows what we want to see based on, how everyone interacts with the program. If we pause on a certain thing or search for certain people or certain types of categories or certain types of plot lines, then they know that based on their millions and millions of subscribers. And what they do is they generate new programming specifically based on what people want. So that's an example of how this is put into practice. But we thought, well, if we can do that for businesses, why can't we do that for prevention messaging? So in one of our original models, which I'm showing here, we identified block groups that were at significantly higher risk for child maltreatment and then did a population level market segmentation to see what the dominant household types are in those areas. So you can see by the different colors that the psychographic profile is very different depending on where you are in the city. So the way that you would use this is if you know that physical abuse is a serious problem in 2 of these places and they're of different market segments, the way that you would approach prevention is entirely different. the magazines that are read, the websites that are visited, the YouTube channels that are prominent, the celebrities that are important, all of those are different depending on the psychographic profiling. And so by doing this, we're able to get a lot more specific about what we want to, how we want to present a message so that it will be absorbed more effectively by the population we're trying to reach. Additionally, by recognizing what people in a certain area like, you can also bring economic development to those areas. So, for example, before we talked about the group that likes to shop at Sam's Club, okay? So let's say you were wanting to bring economic development to this particular area. Well, if you know that they like to shop at Sam's Club and there isn't a Sam's Club there, you can place one there and have relative certainty that it will be successful based on the market segmentation. So it's an additional way to create economic development in an area. Another thing that we've done with psychographic analysis is look at how it can be applied to recruiting foster and adoptive families. So we were able to do a market segmentation of statewide Texas foster families and foster to adopt families, and then we applied those results in Austin with a partner that we have called Upbring, which is a foster and adoption agency. So this is what I'm showing you here is a risk terrain model for the city of Austin. So this is where we predicted child maltreatment would occur, and this is where child maltreatment actually occurred in the following year. And in Austin, we're able to take the predicted risk area for more than 60% of all cases down to about 6% of the city's area. So then, if you want to figure out where to focus your efforts for foster or adoptive recruitment, you look to psychographic analysis. So what you see here, all of these black dots, are actual households that fit into the two categories, 2 of 71 possible categories that are very likely to foster, to do just contracted foster placement of children in the area of Austin. So with this information, you can see that the households cluster in certain areas, and so if you're looking to recruit people, you're going to go to a place where that type of psychographic profile clusters, because those are the people that are going to be the most receptive. So that's an example of what you can do with that type of information. Lastly, we can find where these children are, we can align services, we can work on new prevention programs, we can align messaging and use psychographic profiling for economic development and for improving prevention messages and programs. But how do we know if it works? This is, to me, one of the most important things. None of the rest of it matters without how does it work. Well, it's a challenge in child welfare because people rely so much on subjective information to see outcomes, to inform what they're calling outcomes, really. And what we're interested in is objective outcomes. So just as a very short example, in September of 2016, the United States, the Federal Health and Human Services Agency announced new standards to further their Head Start programs, which are early learning type programs. But the standards which are listed here are things like raising educational standards and curriculum requirements, or increasing the amount of time that children spend there, or affirming the roles of parents, or strengthening services. But my question to you is, does any of that tell you if a child is actually doing better? And of course the answer is no, it doesn't. Think about it like this. Let's say you have a child in piano lessons. At the end of the day, if you want to know if the child is doing well with piano lessons, you don't measure their proximity to the piano for a certain number of hours in the week, or how much time they spent with an improved curriculum with their teacher. The thing you're going to look at is, can they play the piano? That's an objective finding. And this is something that can be consistent across outcomes if we want to look at them in child welfare. So these are just some examples of objective child and community well-being metrics that can be tracked at an aggregate level, even at a risk cluster level, to see if by aligning all of these services, if anything is actually getting better. Are the people that live in these high-risk places improving because they are in this place? Is it where all of the services are aligned and they're supposedly getting the things that they need? Because if they're not improving, if the actual number of child maltreatment cases isn't declining, or if the risk factors for maltreatment aren't declining, then those programs and services should be replaced with something that does work. And this is where accountability for effectiveness really becomes important. And this is also how, if we cover enough geography, if we do this in enough geography by identifying the geographic location, identifying the problems that need to be addressed statistically, aligning services, and then checking to see, looking at objective measures at a population level if anything is working. If we do that in enough places, somebody is going to figure out how to prevent child abuse. We'll see somewhere a reduction in the number of child abuse cases, and that's how we're going to figure out how to prevent child maltreatment. Now, the challenge, of course, is that this data exists across multiple different data systems, not just in Texas, but in other states, and also across the United States. It's also a problem that the federal government faces. There's only one bill that I've been able to find that has actually addressed this issue, and it comes from the General Assembly of North Carolina, House Bill 767, and they call it the GDAC. So what this did, it essentially caused the agencies in North Carolina to put all of their data into a central analytics hub. Now, at first, it wasn't intended to address child welfare. It was to look for fraud and for duplication of efforts across different agencies. But now, people there are starting to recognize the value in child welfare, and they are using this to start to look at different elements from different sectors, different agencies, different environments, different focuses to see how they all relate together. Because we know they do based on the maps and just based on logic, but now we can show it, we can prove it. So to try to develop something similar in Texas, we've begun to work with the Texas Advanced Computing Center, which is part of UT Austin, the UT Austin system, and therefore a branch of the Texas state government. So they are able to receive information and to analyze information with their world-class data scientists and visualization experts that are able to give us information in a way that can be consumed by the public and also by legislators, so that we can all see how, by working together, we can actually improve child welfare. So in closing, first, I'd like to welcome anyone that watches this to please contact me. These are all options of ways to contact me on Twitter and also on Pinterest. I like to catalog articles and prevention programs and inspiring speakers and that sort of information for people to look at. Also on Facebook. Our center's webpage is preventchildmaltreatment.org, and Dyann.Daley@cookchildrens.org is my email. An alternate email is also available through my Twitter account. And so, to leave you here, I guess my request and my challenge is to look inside of your community and inside yourself and see if we can find a way to use the information that's present, the data that we already have that doesn't require additional surveys or additional studies, to look at what already exists and to use it to improve the safety and the welfare of little children, especially the ones that are age 0 to 3 and at risk for fatality and can't even speak out for themselves. Now, sometimes this is a little bit of a challenge because this framework that I suggest is disruptive. It's different than what's being done now. It is definitely against the status quo, but it isn't reasonable for any person, agency, or organization to place their position, their status, their job, their title above the needs of children. And so if the data tells us that we need to move in a direction that helps us to engineer good outcomes for vulnerable children, then that's what we need to do, regardless of any other type of trapping that could try to get in the way. So I invite you to join me in this fight, because it probably will be a little bit of a fight, to prioritize children and to put the child back in child welfare. Thank you very much for your attention today. I hope to hear from you soon.